Hello, everybody. Today was a day, wasn't it? I don't know what was going on with my GTM, but I'm not going to worry about it. We all, as a group, have gone through a lot, and we're going to keep on moving. We're going to keep on kicking it. The first thing that I wanted to tell you about was here is a picture of your final exam blueprint. If you are able to answer all these questions appropriately, you will do good on the final exam. Remember, it is a final exam. Um, Look up under each chapter, it is cumulative. And if you know how to do the things that you need to do by here, is fine. Now, the majority of the tests, which I would say probably about 60% of the tests, will cover some of the items that we was going to cover today. Mainly chapter 18, which is breast regional lymphatics, 27 female GU, 31 the pregnant woman, 32 the older adult, and number 30 bedside. Chapter 28 is not per se on the test because that's just doing your final assessment. That's just how you perform a final assessment, and you have a video in which to do that. Enclosed within your PowerPoints, you will see a couple videos. One of them mainly will be the one with the girl in doing what I call the 10-minute assessment. And within the 10-minute assessment, remember I was telling you guys that you can go to clinical and you can do a quick little assessment. And that'll just kind of show you what type of things to pick up on, how to do like little focus exams and that type of thing there. Just look at it and good luck on your cumulative exam. Like I said, anything is game, and there's 100 questions total on that. Let's start off with the breast and regional lymphatic assessment, which for you guys is chapter 18. Okay, so you have the breast and regional lymphatic assessment. It's composed of the external breast, which is the breast, um, the nipple, and the areola, which is the pigmented area that surrounds the breast. And a lot of times that little area of the nipple may be indented with tiny milk duct openings. Um, the areola is usually between 1 to 2 centimeters in radius, and in the areola are small elevated sebaceous glands, and those glands are called Montgomery glands, as you can see here, Montgomery glands. Uh, they secrete the lipid material that you have that's doing lactation. So breasts are present in men also, and they're pretty much rudimentary throughout your lifetime. Um, there are 15. Oh, I do want to let you guys to know that the breast, as far as the internal anatomy of the breast is composed of glandular tissue, fibrous tissue, and suspensory ligaments. Okay. The glandular tissue contains 15 to 20 lobes radiating from the nipple, And then you have the suspensory ligaments, which are Cooper ligaments, and they are fibrous connective tissue extending vertically from out the skin. Okay, so that's what they are for. So you have a breast area, and the breasts are usually divided into four quadrants. Um, the central axillary nodes, um, the central axillary nodes are high up in the middle of the axilla, and they're over the ribs, and they receive lymph from the other three groups of nodes. You have the pectoral, which is considered the anterior area, the pectoral. Right here, you can see you guys anterior, and along the lateral edge of the pectoral ralis major muscle is just inside the anterior axillary fold. You have the subscapular or posterior, uh, the subscapular, okay, right there, and it's along the lateral edge of the scapula, deep in the posterior axillary fold. And then, of course, you have the lateral. And the lateral area is what runs in the inside of the arm, right here, and along the upper arm. Uh, and this is the reason why a lot of times you'll see in people where if they have breast cancer, they be asking whether or not it's spread to the lymph areas. And a lot of times it can superimpose somebody, make a person be um, where they can't use their arms or whatever if it's spread a lot, and they have to go in there and they have to remove a lot of that lymph. So that's why it's so important to check, so that if you do catch any type of breast cancer or something, it's probably best for you to try to catch it as soon as possible. Okay, so as far as developmentally, um, they have a lot of little different things you could talk about. Like for instance, um, they have what they call acute, occasionally, up under the breast area. It may look like it's a little area which looks like it might be an extra nipple, and that area is called a supernumerary nipple, and it doesn't cause any problem. It is considered a, um, a normal variation. Um, um, Usually, the onset of breast development is between 8 to 9 years old in African American girls and 10 years for white girls. However, recent evidence has even shown breast development in 7 year olds uh, as early as that. Um, so they have various what they call, um, I could say, um, staging. And in the staging, you have what they call the sexual maturity rating in girls, and it's called the Tanner staging. And you'll look at it and see it in the table. And they have pre-adolescent, breast bud, uh, which includes the breast and areola, and then the areola and nipple. And so the staging goes all the way up to stage 5, up to a mature breast. So just take a look at the pictures and try to make like where you're looking or you're thinking about it as far as the variations of the breast development, and what type of changes. In a pregnant woman, Usually there are changes during the second month, which really shows early signs of pregnancy. Um, uh, the breasts usually enlarge. They might feel a little bit more nodular. The nipples may grow darker and larger and become more erect. Um, After a woman starts to lactate, usually um, it fades. And after the fourth month, you'll have what they call colostrum, and that can be expressed. And this thick yellow fluid is what they consider the precursor for the milk. And it contains protein and lactose, and it really doesn't have any fat. So the breasts produce colostrum for like the first few days after delivery, and that's the best time for the child to suckle the breast because the milk they can get antibodies through the colostrum, and then after 1 to 3 days after delivery, that's when you really get what they consider the milk production or the lactation, and it's more of a whitish color, and it contains more fat and calcium. For a aging woman, you may see the breast tissue start to what they call atrophy, and it's all the glandular tissue, and because of the decrease in estrogen and progesterone decreases, the fat atrophies, and it begins in the middle years and it becomes marked in like the 70s and the 80s, and you'll see breasts droop and sag and that type um, of thing like that. If you look at it, the fact that the breast size uh, um, is smaller, the inner structures that's inside the breast become more prominent, and you can see things better. So therefore, things like, for instance, if they had a lump, you may be able to palpate it more readily. uh, their axillary hair starts to decrease and that type of thing as well. So in the male breast, sometimes there is extra breast tissue, especially in male adolescents, and it's usually temporary, and that's called gynecomastia. And it's usually temporary, as I said, but you have to really kind of reassure males because they're very funny about how they view the things that they view. And uh also in the aging male, uh as a male gets older, you'll see that even then um they breasts seem a little droopier because of the fact they might have a little decreased testosterone. So, as far as genetics, cultural, BRCA1 and BRCA2, these are tumor suppressor genes. Um, if a woman has a mutation in any of those genes, that's what increases her uh, uh, ability to have uh, breast cancer or predisposed. So white women have a higher incidence at age 45. African American women have a higher incidence before age 45. African American most more likely to be diagnosed with regional or distance cancer and have lower 5 year survival rates. The reason why that is because of the access of health care. And then dietary influences increases the risk of breast cancer. Like for instance, if you're more obese, if you have increased intake of alcohol, or if you have more weight gain, that tends to put you in a position where you're more likely to uh, have breast cancer. So, as you're examining the person, you guys, you examine the breasts, you examine for pain, lumps, discharge, rashes, swelling, trauma, or history of breast disease. Any recent surgery, what type of self care behaviors? When did they perform their last breast self exam? When did they have their last mammogram? You want to find out all these type of things, and you want to make sure that the woman has been doing whatever they can. Also, always remember when you're assessing the breast that you're going to assess the axilla. You're going to assess for tenderness, lumps, or swellings, or any type of rash. Rash could be because of the fact that they might be allergic to a particular type of deodorant or something of that nature. So you need to just keep that in mind. So while the patient is sitting up, you want to look at the general appearance. You want to look at any type of shape. You want to look and see if the breasts are symmetrical. It is sometimes common for you to see some women as far as symmetry, maybe one breast just slightly bigger than the other, not a lot, but this being something that is just common. You want to look at the skin color. Like I said, assess when you're looking at the lymphatic areas and the axillars, the nipples, and the areola. Okay, so then you will also want to do what they call the retraction assessment, and that's when they put their arms of their head, hands on uh, their hips, pressing palms together and leaning forward. So you want to look and you want to make sure that everything is lined up and things are the way that they're supposed to be. I didn't know if so when you are checking the breast, you want to do the axilla area. It can be done while sitting up, and you want to compress the nipple. You want to palpate in a consistent order, and you may also use the bimanual technique where you can use both hands. You can go up, down, up, down. You can go out, and then you can also start and let the nipple go out in a circular motion. You can do all those type of ways to assess whether or not a person has breast cancer. You want to look and you want to see if it's a lump is possibly present. If they have a lump present, you want to look at the location, the size, the shape, the consistency, the ability to, if the distinctness, the tenderness, whether or not you can manipulate it and that type of thing. You want to look at all of those type of things to see if it's any abnormalities. You do want to do some health promotion. You want to always teach a woman uh, basically how a schedule for a self breast exam, and you want to always tell them to describe the technique. And then after you tell them how to do the breast self exam, you want to make sure that they do a return demonstration. I would tell everybody to make sure that when they do the breast self exam that they do it basically like around the same time of the month. Sometimes a good way to do it is to do it sometimes in the shower, but the best time to perform a breast self exam is right after the menstrual period, day 4 or 7, uh, 4 to 7 of the cycle when the breasts are um, the smallest and least congested. So that's usually a better time. And also a good time if you can have them even do it in front of a mirror. You got to make sure that you reinforce that they disrobe at the waist, um and they palpate in the correct areas, making sure that they cover all the areas including the axilla. The male breast can be abbreviated, of course, but that's something that you, of course, may want to do as well, because sometimes a person can be on anabolic steroids or some medications or something like that, and those type of things or will come into play, and you may see a guy get what can I say, gynecomastia. So they have the United States Preventive Services Task Force. This works on making sure that biennial, so every 2 years, from age 50 to 70 years, um, they will get a clinical breast exam, which is a CBE, which means a mammogram, and also have the doctor take a look. The American Cancer Society has an annual mammogram at the age 40 and above. At the age 40 above, clinical breast exam every 3 years during 20s and 30s, and annually at age 40 and above. Self breast exam is optional at age 20 and up. Um, if a person tends to have some type of history in their family, they may be performing breast exams, which is perfectly okay. So self breast exam monthly, clinical annually, and then mammogram at age 40 and above in every 1 to 2 years. Okay, so if look at that, and that can help you as far as what you need to be. Self breast exam monthly, a clinical breast exam once a year, and then the mammogram between 1 to 2 years if they're over the age of 40. Okay. And then, of course, like I said, that will be changed if you got somebody that may have a strong history of breast cancer in their family. Right here is Uncut Woman Shares Her Breast Cancer Story. A pretty young woman. You can listen to it. The tape is only about 6 or 7 minutes long, but please go in up under week 9 and look at it. The PowerPoint is one of the last ones, and let this woman share her story. I can play it, but I don't know if, yeah, you guys may be able to hear it. Let me see.
Okay, well, just kind of walk me through, Amy, what happened. How did you find something? What?
Well, in February, when my son was 6 months old, I was having a tiny bit of pain in my right breast, and I was just sort of exploring and felt a small lump, and I thought, and I was breastfeeding at the time, and I thought I had a clogged milk duct. So my sister is actually an RN, and I had her just briefly check it out for me, and she thought it was a clogged milk duct as well, and I sort of just moved on and didn't feel really right about it, so I went to the doctor, and they thought it was a clogged milk duct too, and they told me to just put heat on it, massage it, do all these things to it, which I did for 4 months, and it grew. They kept growing and growing until it was 3 centimeters. And at that point, my son was 10 months old, and I thought I was getting mastitis, and I was in a lot of pain. I was having chest pains, and I was very concerned at that point. I had to go back to my doctor. I went to my primary care physician at that point, and they sort of, I think, knew at that point, even in the office when I went in, and had me in seeing doctors all week and getting testing, mammograms and sonograms and MRIs, and I found out the next week that I had breast cancer.
How far along had it moved?
Very quickly. I was at a grade 3, which is the fastest growing breast cancer there is, because it grew from the size of probably a kidney bean to the size of a golf ball in 4 months, which is not good. And I'm at a stage 2 breast cancer right now, and it had spread to 1 lymph node, which is better than it spreading anywhere else. So it's sort of positive. And then I had a radical mastectomy 3 weeks after I had found out. So.
And all of this while going through the separation of not breastfeeding Harrison and all the emotions that go. I mean, the span of emotions you must have been going through has got to be unbelievable.
Yeah, it was very difficult. The worst day of my life was finding out that I had cancer. The second worst day was, losing my breast, and then having to quit breastfeeding overnight was awfully very hard emotionally too. So it's been very difficult on our family, but there's been some major positives too come out of it. So
tell me about the positives.
You know what? It's been extremely life-changing in a positive way. My husband and I have become extremely closer. I don't like to say I'm glad I got breast cancer, but I am, because I've actually, I've grown closer to God, and just my life has changed for the better. So people have just come out of the woodworks that I haven't seen or talked to help me, and my life has changed for the better because of it. So it's been a big mountain and a road that we're climbing right now, but I know, we're just going to get through it, and it'll be over someday.
Yeah.
So.
Well, explain how your week goes, because for anyone who has not undergone cancer treatment, they don't realize that it's like the minute you start to feel better, it's time to go in for that next treatment. So just explain your week to me.
Well, if you can get me in the car to go to my treatment, it's hard enough as it is. You basically have to drag me there. My husband does. I make him go with me. So he takes the whole day off work because it's just dreadful. I start feeling awful that night. I usually call it just 10 days of it's just horrible. I don't do anything for the first 10 days. I just lay around. I'm extremely nauseous. I've had horrible side effects. I've probably every single side effect that you can imagine. I mean, my hair is all gone. Obviously, that's pretty normal. And I've had neuropathy already, which is a hand and foot problems, and some thrush, and a whole bunch of mouth sores, and I can't sleep. It causes horrible insomnia. But just when I'm feeling awesome again, which is right about, I'm starting to feel really good right now. Now, today, and then on Wednesday will be my best days. And then Thursday, I have treatment again, and then it'll start all over. So that's about how it goes. So right now, I'm nesting. I call him nesting. I start doing the laundry, cleaning the house, getting the grocery shopping done because I can't do anything.
Finally have enough energy for the
Yeah,
next 3
energy.
days to get up and do stuff and not pooped like gotta go lay down or anything.
Yeah.
So.
Right. Okay, well,
So, just looking at her, this woman's journey, that'll give you an idea of what type of thing a person goes through. As far as when you're a nurse, and as far as the documentation of somebody, when you're assessing and you're doing their breast exam, this is the type of thing that you would put. Of course, you would put your subjective and then your objective, what your assessment is down there, which is um, what you think based on your subjective and objective assessment is the outcome for that individual. And then from there, you will put your plan. And a lot of times the plan always includes some type of teaching. You know that, you guys. So that'll be the end of that show. And now we'll start on your chapter 27. Um, chapter 27, I'm sorry, will be the female genital urinary system. Um, so we'll start with that one. Looking at the structure and the function, you have the external genitalia, which is the vulva. Uh, um, and I do want you guys to be aware of what is considered, I could say, um, the external part, the mons pubis, um, which is that adipose tissue that covers the symphysis pubis, and then you have the labia majora, and then the labia minora here. Okay, so always think about the labia minora as being the smaller of the two skin folds, and then up here, you have the clitoris, which they consider that they could describe it as a P-shaped erectile body. Um, it's supposed to be almost like you can consider that just like the male penis, really, believe it or not. The vaginal orifice. You have the hymen here. Usually that area is intact on, it's particularly people who are virgins, the hymen area, the frenulum, and let me see, the Skene's gland right here. Um, the Bartholin's glands, and just knowing, you see right here where it says urethral meatus, that's the area where you would put actually the if you was giving somebody a Foley catheter in that area there. And that's the part where a lot of times people tend to go wrong at. They'll put it in the opening to the vagina, the orifice, and they're supposed to be putting it up here at the urethral meatus. Okay, so then you have, and it's very important, like I said, for you guys to understand the internal genitalia as well. Um, the internal genitalia is the vagina. Um, the vagina is the canal or the orifice. You have the rugae, which is the area which allows the vagina to, I guess you could say, to open up, especially during childbirth. You got the cervix, which is the opening to the uterus, the actual uterus. Um, the opening, that little opening of the cervix is called the eyes. And then you have the fallopian tubes and you have the ovaries. So here is showing a picture of the openings, just knowing the areas that are concerned. So when you do uh, an assessment of a woman, of course you're gonna ask subjective questions like, date of the last period, age of first period. You're going to ask them um, if they've had any obstetric history, like giving childbirth, whether or not they're on menopause, self care type behaviors, um, menopause is when they stop having their menstrual cycle, and they said from it can go up as early as 40-year old to 55 when they first start having those periods of time. When they do that, you do want to know about self-care behaviors because that's like very, very important. Oh, I did when I forgot to tell you guys as far as pregnancies, but I'll go into the gravitas stuff when we talk about the pregnant female. You want to know about any past history, any problems they've had, whether or not they're having any urinary system, any vaginal discharge, what their sexual activity is, whether or not they're using any contraceptive, whether or not they've had contact with anybody who have had a STI, and based on their behaviors, whether or not they're at a STI risk. You want to know all of those type of things. When you look at things like self-care behavior or STI risk or anything of that type of nature, um, that is a really good point in time to do some teaching. So you want to inspect the external genitalia for symmetry of the labia, whether or not the mucosa in the inside is uh, intact or pink, and if there's any even distribution of hair, whether or not they have any no lesions, masses, cysts, drainage, nits, or lice. uh, when you're going to palpate the urethra and the Skene's gland and the Bartholin's gland bilaterally. When you do a speculum exam, and unless you're working in I guess I could say unless you're working in that area, you may not be able to or need to use a speculum. But basically, it's showing you here how you insert it and then you have to turn it. And this right here, this picture here is showing you how it looks because this is the opening of the cervix. So this is where you would get your culture and that type of thing. And they're in the lithotomy position when you do it. Make sure they always have their bladder emptied before you do it. If they have somebody in the room with them before they get an exam. Make sure they leave. A lot of times, if there's a male doctor or a female, they'll have a nurse or somebody in there with them when they do the exam. Um, Make sure they have their legs on the spectrum. You can also give a person a mirror if they want to see what's going on. Doing that inspection. And also make sure the speculum, they're using more plastic ones now. Make sure they put lube on it. Make sure the speculum is not too cold or that type of thing, because they used to use the metal ones, but they don't use those anymore. And it's the proper, and then you want to give a bimanual exam. So you're to see if there's any pain, any cyst or anything. So while you got your fingers in the vagina going into touching the top of the cervix of the uterus, you put your other hand and you press down on the lower abdomen. And this shouldn't cause any discomfort. Okay, and then the recto is kind of almost the same thing. One in the rectum, one in the vagina to make sure that they don't have any fissures or they have an intact septum. So, as far as health promotion is concerned, you do want to make sure that you assess whether or not they have a HPV vaccination or anything like that, that they are having regular pap smears and that they're having safe sex uh, practices. Okay. Um, um, they do have pictures of very normal variations of the cervix where it'll show how the cervix look, whether or not a person has had a child before or something of that matter. There's different variations, and I would ask you to just look at it, okay? Okay, so here's the documentation, and it's basically telling everything. Like, for instance, it's saying gravida zero, para zero, which means they've never been pregnant, they've never had any children last cycle. It has a date there for it. And then your observation when you're doing it, it has everything in here. And so basically, you're saying you want this person to have a pap smear every 3 years and safe sex practices, and they got a healthy genital urinary practice. Okay, so we'll get ready, and next, you guys will be doing chapter 31, the pregnant woman. Okay, so talking about the pregnant woman, that I am not an OB nurse. Like I've told everybody, children and pregnancies are two things that I really don't choose to deal with, but I will give you a limited amount of information on them, and you will be taking OB, so you'll really go into depth. But I will tell you some things that I feel that all nurses should know about pregnant women and should understand, about pregnant women. I feel like a good med surg nurse can do almost anything, So, starting on the pregnant woman, which would be chapter 31, um, you're gonna do a development review. And as far as the development review, I want to tell you guys the follicles develop during the first 14 weeks. One dominates and ruptures with, 14 days, I'm sorry. One dominates and ruptures with ovulation at about day 14. Okay. The remaining eggs are corpus luteum or yellow body, which makes hormones. Progesterone prevents endometrial sloughing, and that is what we call our menstrual cycle. Okay. After the egg is fertilized and grows into a blastocyte, it produces what they call HCG. HCG is called human chorionic gonadotropin, which stimulates the blastocyte to continue to make progesterone. So on day 20 and 24, implantation in the endometrium happens. And then the cells surround the blastocyte and they form the placenta, which assists with um, oh, sorry about that. Phone went off and I just had to hop off. But the implantation, and this is all you guys, like how the fetus grows, what happens after it was fertilized. Let me make that clear. So the implantation in the endometrium is days 20 to 24. And then after that happens, the blastocyte, which is the fertilized eggs, it forms the placenta, which is this way of getting nutrition and blood flow and antibodies and that type of thing. It assists with progesterone production, and at 7 weeks, it takes over with it at 10 weeks. So we have the placenta. The placenta produces progesterone, and progesterone supports the pregnancy at 7 weeks and takes over this function completely from the corpus luteum at around 10 weeks. Remember, I said that? HCG, which is the human chorionic gonadotropin is that hormone, and it helps in the growth and maintenance of the fetus. That is the hormone that they're looking for when you take a urine test. When you take a urine test to find out whether or not somebody is whether or not somebody is pregnant or not, um that's they can tell by the amount of human chorionic gonadotropin whether or not a person, if it increases, um then they know that a person is pregnant. Okay, I do want you guys to remember that the average length of pregnancy is 280 days from the first day of the last menstrual period, which is equal to 40 weeks or 10 lunar months. Okay. Um, with or 9 calendar months. Note that this includes the 2 weeks when the follicle was maturing, but before the conception actually occurred. Pregnancy is divided into what they call 3 trimesters. The first 12 weeks, the second from week 13 to 27, and then the third from week 38 to delivery. So know about 10 lunar months, which is 9 calendar month and 280 days from the last day of I'm sorry, the first day of the last menstrual period, and that is equal to 40 weeks. That is a normal pregnancy length. Okay, so you have pregnancy terminology. I do want you guys to know about pregnancy terminology. For instance, gravida. Um, any Any woman that is pregnant is called gravida. Okay? Any woman that's pregnant is called gravida. A woman who is pregnant for the first time is prima gravida. A woman who has never been pregnant is nulla gravida. So gravida is the pregnancy times. Prima gravida is the first time pregnant, and nulla gravida is never been pregnant. Then you go into the para. Para is actual live um, births. Parada is actual live births. So if a person is a prima parada, they've had two, they have one live birth. Multipara, multiple, and nullipara, none. Okay? And then they have basically the viability and basically whether or not they've had babies that have survived, you know. So a person can have, you guys, a gravida too. They could be like gravida uh, 2, para 1, which means they've been pregnant. Uh, how can I put it? Pregnant 2 times, but only had one live birth. And then they may have a AB1, which is um, abortion of some type or preterm, you know, or like full. So like down at the bottom, you'll see, for instance, you'll see where it has all the living, abortions, paras, term, full term, you know, like gravida. So you can look at a person's picture by that. Um, you could have somebody, and I want y'all to write this round down, G5, T3, PTO, A2, and L3, which means that they may have been pregnant 5 times. Um, they might have 3 that they had full term. They haven't had any preterm um, deliveries. And then they had 2 abortions, and then they have living children 3. So that's what that means. Okay, this, you guys, oh my God, you have to know this because I may throw a question on here. Know the signs of pregnancy. You have what they call presumptive signs, or those that the woman experienced. Like they may have amenorrhea, breast tenderness, nausea, and fatigue, urinary frequency. Amenorrhea, I'm sorry, you guys, meaning that they don't have a period. Okay, that's presumptive. That means that you presume that you may be pregnant, but just because you have those symptoms, anybody could have those symptoms for a number of reasons. Okay, then they have what they call probable signs, which mean enlarged uterus, a Goodell sign, and a Chadwick sign and a Hager's sign. So I'm going to explain to you what those signs are in a second. And rising ACG levels, probable. Um, those type of signs or signs that is letting us know that a woman is pregnant or whatever when they do um, the actual examination on a woman. But the only real positive, the only real positive sign of actual pregnancy is if you can hear the fetal heart tone and you can visualize whether or not a person the fetus has a um, heartbeat during ultrasound. So, like, you can hear that boom, 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 and you can see during the heart, um, um, during the heartbeat, you can see whether or not a person has those signs. Now, I told you, I forgot to tell you what Goodell sign, Chadwick sign, and Hager sign is. I would like you to know these are probable signs, along with the enlarged uterus and the rising HCG levels. Okay, so um, Goodell's sign is when a person is examining the cervix, because a lot of times, when you go in, you guys, and you get the cervix examination, um, they notice a degree of what they call effacement or thinning kind of, and then the cervix is kind of soft. That's the Goodell sign. The Chadwick sign is the bluish purplish discoloration of um of the cervix and the vaginal wall, and that means there's more blood there. um there's more engorgement, there's more vascularity there as a result of the fetus. So that's the color. The Goodell's is the softening. The Chadwick is the color. And then the Hager, this is called dextro rotation, and that's when um, the large uterus bends forward onto the isthmus, and that happens during the 4th and 6th week. So you'll see that bending forward of the uterus. And then, of course, I told y'all about the rise in HCG levels, the human chorionic gonadotropin levels. So I'm going to emphasize this once again, you guys, that I really, really want you to remember the signs of pregnancy: presumptive, probable, and positive. Know the difference between presumptive, probable, and positive signs of pregnancy. Okay, so um, the first trimester, they're going to have presumptive symptoms with probable signs, confirmed with positive signs. Um, they're going to have presumptive signs and they're going to have probable signs. And then what you do is you want to confirm it and make it positive by doing a fetal heart tone and an ultrasound. You want to check the fundal heights. You want to have the increase in human chorionic gonadotropin and progesterone levels of the hormones. At the 7th week, the blood pressure usually begins to drop because there's peripheral vascular resistance. And then the embryonic period ends at 9 weeks. The fetal heart tone can be detected at 9 to 12 weeks, and you can palpate the uterus above the symphysis pubis at 12 weeks. The second, which the second trimester is when you really, truly, truly see it. A lot of people tend to, between that 12 to 27 weeks is when it's the real deal. They usually stop after the 3rd month, which is 12 weeks, um, being as nausea, aided, and vomiting, and even the urinary frequency tends to improve. Even though there's a little bit more pressure on the bladder, they tend to get more used to it, and it don't seem like they're going as much as they even went at the very beginning. There's what they call quickening, which is at 18 to 20 weeks, you can kind of feel the baby fluttering. You have the breast changes occur, which the colostrum. Remember, I told you the colostrum, the yellow substance that has the antibodies and that stuff can be expressed. The nipple and areola is darker. They have striae and they have linea nigra. Linea nigra is that dark line that goes down the center of the abdomen, and the striae gravidum is what you more or less would call stress marks. The blood pressure is the lowest at this point, and sometimes people may tend to have periods where they may faint or get dizzy. They have heartburn because of that pressure and the fetus is getting bigger, constipation, gallstones, um, increased respiratory tidal volume. Some people have a decrease in thyroid stimulating hormone because uh, they have an enlarged thyroid, so therefore your body's telling you, the pituitary is telling you not to produce as much thyroid stimulating hormone. Gums may hypertrophy and bleed easily, which is eupilus of pregnancy. Now the gums and that kind of stuff, and that's really something because a lot of times you have to stress for women um, uh, during that pregnancy period to take care of their dental areas and things like that. They can palpate outline of fetus at about 20 weeks. And after 20 weeks, the fundal height is measured in centimeters and equals weeks of pregnancy. So once the 20 weeks, you want the baby to be 20 centimeters, and 21 weeks, 21 centimeters, that type of thing. The 3rd trimester, um, blood volume increases to a max of pre-pregnant volume. The erythrocytes increase by 20 to 30. The hematocrit level may decrease. You may see people get a little bit of a little less iron in their body. The blood pressure increases to pre-pregnant level. It's no longer supposed to be uh, um, um, low anymore. Uh, their rib cage is bad. They have lungs are compressed, which can sometimes cause shortness of breath, and pulse usually increase, and they have increase in cardiac output, stroke volume, and force. All of that increases. The lower extremities, sometimes you'll get people that'll have edema or swelling to their lower extremities. Uh, they may have varicose veins, hemorrhoids, and I told y'all about the sway back, which is lordosis, and then they start to increase urinary frequency once again. So, labor signs. If the term is considered 37 weeks, you guys. So, if a person is at term, they're 37 weeks and above. You'll get that lightning, which is about 2 weeks prior to them having a baby. And lightning kind of is almost like you're getting ready, like you're having a lot of movement and fluttering and stuff. Increased frequency in vaginal secretion, increased lung capacity. They'll lose what they call the mucus plug. Flu-like symptoms. Sometimes they have Braxton Hicks contractions, which are what they call fake contraction, and the labor confirmed by effacement and dilation of the cervix. So they'll confirm that the cervix and the bottom part of the perineum area of the woman is thinner, and that the cervix is starting to dilate. You know, you deliver when it's at 10. So it may dilate to 2 or 3, you know. Here is the gestation analysis and developmental considerations. Here, you guys, is a pregnancy wheel. Please take a look at it. Um, they have a way to tell you your due date, and I do want you guys to know this. So, Nagel's rule is um, you get the last month and day of pregnancy, last menstrual period, and then you add 7 days and subtract 3 months. So, they'll tell you my last menstrual period was on this particular day. And you will decrease, subtract 3 months off of that and add 7 days. Take off 3 months, add 7 days from the last menstrual period. That's the Nagel's rule. So the genetic screening, um, um, you need folic acid because that decreases like birth defects and that type of thing. And there are also all different kind of complications that could possibly happen during gestation. You could have hemolysis, which is a lizard, low platelets, which basically you'll be bleeding, pregnancy-induced hypertension, which I had that, um, gestational diabetes. I have a girlfriend that whenever she was pregnant, she would always get diabetes. And then, I mean, I'm talking about hardcore where she would have to shoot insulin and everything. And then as soon as she had her baby, she was done. Um, Preterm labor, hyperemesis. I used to go treat people who would throw up, anemia, hydridiform mole, uh, 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 um, intrauterine growth retardation, poly or oligohydramnios, which is mean the fluid is either too much or not enough of the amniotic fluid, strep and malpresentation, which means the baby might be breech or be wanting to come out the wrong way, and in that fact, they might have to take them out via C-section. So you're going to do your pregnancy assessment, right? You guys, you're going to assess everything menstrual, GYN, OB history, everything that we've discussed here. Then you're going to do objective, looking at everything, breast changes, their gums, their thyroid, all the things I told y'all to look, signs of abuse. What's their blood pressure? Do they have depending pitting edema, which is where dependent means it's in the lower extremities because everything is pulling down. So you're going to assess for all of those things. Deep tendon reflexes. If they have hyperreflexia, they may indicate preeclampsia. Like I said, that's what I had. And um, Eclampsia is when they go off and have a full blown seizure because their blood pressure has gotten too elevated. But preeclampsia is it's a lot of things. You start dumping protein in your urine, your blood pressure goes up, you have edema, all of those type of things. Um, um, Abdominal, you need to do the fundal height, fetal heart tone, presentation, Leopold's. You want to look for all the different signs, the Chadwick, Goodell, and Hager signs that we took detected. And then in the last trimester, you want to look and determine the shape. In the book, they have, and then I think I have it on this slide too. They have different shapes, and they describe different, I guess you could say, um, pelvic shapes of a person, and whether or not that person, sometimes based on the pelvic shape of a woman, um, it could, I guess you could say, interfere with that person's ability to deliver, you know, the way that they are supposed to deliver. And I was trying to see quickly here, you guys, if, because I thought they used to have pictures in the book of the different types of pelvises, but let me see. Here is showing them basically measuring and filling for the presentation of the fetus here. You can look at the different pictures and you can tell how they're telling you what side the because like they have different types of maneuvers, you know, like this on the left side is what they call the Leopold, the first maneuver, um, cause like they have what they call. I'm trying to see if I got it in this. Oh, good, I do have the different types of pelvises. Okay, so okay, right here is the first on the left hand side, guys. Um, That's what they consider Leopold's first maneuvers. Okay, what you need to know about is position, variety, and engagement. They have like Leopold's maneuvers. Okay, Leopold's maneuvers. Listen to me, you guys. You have fetal lie, and that is what the orientation is to the mother's spine. Is it longitudinal, transverse, or oblique? Then you have presentation, and that is, it describes like the part of the fetus that is entering the pelvis. Is it the head? Is it the foot? And then the attitude is is they flexed? Is they military, straight, extended? The position is the location of the fetal part to the right or left of the maternal pelvis. The variety is whether the fetal's back is anterior or lateral or posterior to the maternal pelvis. And then the engagement is the widest part of the presenting part into the pelvic outlet. So that's the little different parts. And like I said, I'm not a big person as far as OB, but they do have like the first maneuver, the second maneuver, the third maneuver, and the fourth maneuver. So it's just they're checking on Leopold's. And then here I do have the gynecoid, android, uh anthropoid, and the plataloid pelvis. There are pictures of the different types of pelvics that women generally present with. So that is a picture that I probably stole from somewhere because at the time I don't think that we have any pictures in our book of the varying types of pelvises that women tend to have. But I would, if I was you, I would just know the names of them. And that is it. I don't really think, you guys, that I need to go too much more into pregnancy about changes or anything because, like I said, I'm not the expert and this is not the class to learn about a whole lot of things about pregnancy. But the things that I did mention to you, I would either replay this area on the tape and then I would move on. The next thing that we're going to do is we're going to discuss the older adult and then bedside assessment. So, number chapter 32 would be the older adult. So, yeah, let's end this and okay, everybody. Chapter 32 is our functional assessment of the older adult, my little old people. Um, we've discussed these before. I don't feel like I need to go into that again. As far as their ADLs, but I would like for you guys to know the difference between um activities of daily living, instrumental activities of daily living, advanced activities of daily living, and assessment of cognition and social domain. When you assess an older person's functional ability, you're always going to assess these things. You're always going to assess these domains. So, no, remember we talked about activities of daily living, which would be uh, doing things like bathing, feeding, grooming. Uh, Instrumental activities would be like if they could shop, if they could prepare their own meal, manage their finances, that type of thing. Advanced activities of daily uh living. Remember, you guys, I talked about things such as hobbies and socialization, uh them being able to do recreational stuff and that type of thing. So the next thing that you would do is they do have some tests, like for instance, physical and that type of thing, like measuring physical of performance for an older person. You would do the get up and go test. it's what they do is they observe the person rise from a chair, they walk 10 feet, they turn and they walk back to the chair and sit down. And so uh you're looking at whether or not the person need to push off, the person is staggering, and that type of thing. So they also have a little thing called Lawton Instrumental Activities of Daily Living. It's like it goes from A to H. And basically, what it does is it gives them a point uh, for everything that they can do well on there. And of course, like the more points that the client gets when they're doing uh, the Lawton, the better, of course, for that person. So it's like different types of questionnaires that they have as far as older people and their how they I guess you could say function. So we talked about activities of daily living, and here is eating, bathing, grooming, dressing, toileting, walking, using stairs, and transferring. Instrumental, shopping, meal preparation, housekeeping, laundry, managing finances, taking medicines, using transportation. And then advanced, self-care, mobility, work, recreation, socialization. Uh, this is the part, the advanced, where my parents tend to fall down on not all areas, but some areas. Assessment of cognition. When you assess a person's cognition, you assess AMO, their attention, memory, orientation, and their language. Okay. For instance, if they have any alteration in they have dementia, delirium, or depression? Uh, you know, a depressed person often complain of memory impairment. So what I need for you to know is that when a person has a delirium, delirium means that that person has a quick or acute change in cognition. Okay, so their ability to understand and that type of thing, and that's delirium. Um, so you want to look at any type of early signs of dementia or anything like that. You know, uh, dementia it happens gradually over the time, and then we know what the person, if they're depressed, you can see it in the way that a person, uh if they're sad, if they have blue moods, if they have periods where they tend to suffer one moment, you know, they can do this, one moment they can't do this. And I mean that affects a lot of older people, like in the community. So you want to look at their social domain because of the fact that their domain can affect the person. Um, you want to be able to look at uh whether or not a person is able to go out in the community, have social groups, and that type of thing, because that affects whether or not they're depressed. You want to look at their caregiver, if they have one. Uh, Things to remember: caregivers tend to have an increase in mental, physical stressors. They can experience caregiver burnout. They can experience sleep disturbances, and the caregiver can also become depressed. So you want to make sure you look at that. And so you want to look and make sure that there's no type of burden. And you could tell if they have burnout because they may start having pains in areas, somatic complaints, stress, anxiety. They may be a caregiver and they may start to isolate themselves from social things because they tend to be just wrapped up in taking care of this person. They can be depressed and they can suffer from weight loss. Uh, you want to look at things like elder mistreatment in the home, omission or commission results in harm or threatened harm to the health or welfare of an older adult. So, what that means when you say elder mistreatment, that means that they're either doing something or they're not doing something that could result in harm to the older person. They have different types of uh, elder they have different types of abuse. They have or mistreatment. I want to say, I don't want to necessarily say that they're um I just want to say that they have different forms. And there's physical, of course, everybody want to know what that is: sexual, emotional, psychological abandonment and neglect. So there are tons of ways that people, and there are some people who are actively out there abusing the elderly for money and that type of thing. Maybe a person was a strong person when they was coming up, and now uh, this child of theirs or old uh, adult offspring of theirs decides that they gonna take out what they felt they didn't get as a child on their parent because their parent is disabled now or can't do. So you need neglecting to get things that they need when you have resources right there in hand to get them for them. All of those things is mistreatment, and be careful that you watch. So the risk factors for that type of abuse is usually females, usually people with 75 years or older. Remember I said limited resources, residing with family, disruptive behavior, social isolation, and if the caregiver is financially dependent on the elder. So signs of elder abuses when a person don't want to leave that person alone. If the elder person is excessively like deferring to that caregiver, whenever they say something they looking at the caregiver. Delays in them seeking treatment for things, inconsistencies with reporting about injuries, lack of hygiene and appropriate clothing, those type of things. So they do have a mnemonic, which is stop harm, and it says screen for abuse in all elderly patients. Think about risk factors, ominous danger signs, physical findings, history, address the issue, report to adult protective services, and manage with prevention and risk factor modification. Um, Always do an environmental assessment. Make sure that there's proper lighting. Get rid of unnecessary rugs that they could trip. Look at the hallways. Get rid of cords. Make sure that they can get grab bars installed appropriately. Sometimes they may need to get raised toilet seats. Uh, make sure that you have people in the neighborhood that know about them that you can rely on. Make sure they're getting proper transportation, and hook them up with the basic community things they need. When you do a spiritual assessment, health may improve as age progresses. People tend to be a little bit more spiritual. And uh, spiritual assessments, they provide personal answers about the meaning and purpose of one's life, and powerful to cope with any type of ailments that they may have. And you can ask a person if they consider themselves to be spiritual, because they may not, you know. So always take into consideration cultural needs of a person, because different cultures are different. Assessing whether or not the people are in pain, because when a person is in pain, a lot of times they tend to act differently. You want to assess elders with altered cognition. So, assessment at the end of life. Oh my gosh, assessment of the driving ability. You have to know when they need to get out of that car. We've done it to my mom. There were various different little things going on, like they almost always crashing. You find dents and stuff. They driving and they getting lost, a lot. Uh, Having trouble seeing. Their misjudgment, as far as gap, getting warnings and traffic tickets. The inability is taking them too long to change lanes, and they seem like they scared. You can look at all of those. With my mom, it was like the dents. It was like the getting lost. It was like it was just a lot of little different things. So we finally got to the point where we was like, So you want to make sure you assess that person's sleep, and their finances, and always review their medications, because older people have a tendency to have a lot of polypharmacy, basically, where they're taking a lot of little different medicines. And I always believe that less is more. And basically, that's it. Um, the next and the last thing that I was gonna go over with you guys was chapter uh 30, which is the bedside assessment. Okay, bedside assessment and electronic health recording. We're just gonna go over, and it's just gonna review some basic little things, okay, that you need to know. Okay, so we're gonna start here with a nursing student. And this is basically, you guys, what I want to show you with this is that you can give an assessment to somebody, and it doesn't have to be like so in depth where you get yourself caught up, and you just be like, oh my god, this is too much. So what I want to do is, I want you guys to watch this. It's a 10-minute assessment, and then we'll move on.
Hi, Mrs. Myers. My name's Jenny. I'm going to be your student nurse from the University of Detroit Mercy. Okay. We're going to be doing a head-to-toe assessment on you. If you excuse me, I'm going to go wash my hands, okay?
Okay.
All right, do you have any allergies I need to be aware of?
No.
No? Are you in any pain today?
Yeah.
Okay, where is your pain located?
In my elbow.
Okay. On a scale of 0 to 10, what would you rate your pain?
A 5.
A 5. Do you need any medication at the moment before we proceed on?
I don't think so.
Okay. Is the pain a dull pain, a sharp pain?
It's a sharp pain.
Okay. Does it radiate anywhere else?
Yeah, to my fingertips.
It goes to your fingertips.
Mm-hmm.
Okay. How long have you had this pain?
Since Saturday.
Did you do anything to make it hurt? Did you fall?
I was helping my brother move, and I think that I might have hurt it, lifting some boxes.
Okay. All right, great. So I'm going to report that to the doctor. Does anything make it better?
I take ibuprofen for it.
Okay, yep. So I'll report that in your chart, okay?
Okay.
So since you said you didn't need any pain medication, we can continue on with the head-to-toe assessment, right?
Yep.
Okay. So the patient seems to be dressed appropriately. There's no obvious signs of body odor. Her speech is normal with a normal rate and volume. Can I check your wristband, please?
Yeah.
Can you say your last name for me?
Myers.
And what's your birthday?
11/10/90.
Okay. And where are you right now?
I'm at the hospital.
Okay. And what's the reason as to why you're here?
For an assessment.
Okay. So the patient is alert and oriented ×4. The patient doesn't seem to have any obvious signs of distress or illness, so I can continue on with her assessment. So first I'm looking at your skull. The skull is normal cephalic. There is no obvious signs of lumps or bumps or lesions. There's no infestations in the hair. Go ahead and put your face up. The skin is warm to the touch. There is an even skin tone. There is a nevus on her right upper cheek. It is symmetric. The border is even and accommodating. There is an even color. And the diameter is less than 1 centimeter, which is less than a razor head, and is not elevated. So I'm going to write that down for you, okay? So the skin, like I said, is even skin tone. There's no lesions. There's no drooping of the facial features. So what I'm going to have you do is I'm going to press on a couple places of your face while I have your eyes closed, and you're going to tell me where I'm pressing, okay?
Okay.
Close your eyes. Forehead.
Nose. Cheek.
All right, great. So that is testing your cranial nerve 5 for your facial sensation. So now can you smile big for me and puff out your cheeks and raise your eyebrows. Okay, so cranial nerve 7 is also intact. So now I'm going to be looking into your eyes. You can stare straight ahead. Great. So your pupils are equal, they're round, and they did constrict with the light. If you can stare straight ahead at my pen as it goes towards your face. Nice, and they did converge as well as constrict. So therefore the pupils are equal, round, reactive to light, and accommodation. So now let me see your conjunctiva here. So look up for me. It is clear, glossy, there's no signs of inflammation or cyanosis. So now we're going to be looking in your mouth. Go ahead and open your mouth for me. The mucosa is nice and pink. There is no signs of lesions or any type of cavities of the teeth because they are nice and white and evenly spaced. Go ahead and stick out your tongue for me. The tongue is moist and say ah. Ah. The uvula raises midline when you did say ah, and your tonsils are graded at about a +1 because they are present. However, they're not inflamed, so that's a good sign. So now I'm going to look at your carotid arteries. So I'm going to palpate this real quick. Good. Okay, both of the arteries are equal bilaterally. They're rated at a +2. So now I'm going to listen with the bell. When you feel my stethoscope, I want you to breathe in and hold it, okay? Nice. One more time. Okay, I did not hear any signs of bleeding. Okay. So now we're going to be moving down your arms here. The temperature is even, the hair distribution is even as well. The temperature is warm. Go ahead and flip your arms over. Her brachial pulses are equal. They're not bounding. They're rated at about a +2. Move down to your radial. Those are nice and, there you go. They're rated at a +2 as well. Flip your hands over. Your nails are nice and clean. The capillary refill is at less than 3 seconds. There's no clubbing of the nails. I'm going to test your strength, so if you can grab onto my hand, nice and tight. Good. There is no weakness of the upper extremities. So now we're going to listen to your heart. Okay, so what we're going to do is in the second intercostal space, I'm just going to do that while I'm doing this. Is her second intercostal space is the aortic, and that I should be hearing S2 sounds. Move over here to second intercostal space is pulmonic. Also S2 sounds. Third intercostal space is going to be the herbs. Fourth intercostal space is the tricuspid, which should be S1 sounds. And then the mitral sounds in the fifth intercostal space, mid-clavicular line, should be S1 sounds as well. I'm sitting here for 60 seconds. Okay, listening to the apical heart rate. Flip it around to the bell, and we're going to be going upwards, backwards from mitral, tricuspid, ergt, pulmonic, and aortic. Great. Don't hear any abnormal S3 or S4 sounds, which is good. So now I'm going to be listening to your lungs. So every time you feel my stethoscope, if you could take a deep breath in for me, okay? Okay. Okay. Okay, you can start to breathe normally now. Alright, so I'm going to move to your back and do the same thing. Right up in there. Go ahead, deep breath for me. Nice, now you can breathe normally. Okay, can you raise your arm for me and take a deep breath? Alright, great. I don't hear any adventitious lung sounds, and that means your lungs are clear. So what I'm going to do is I'm going to test any tenderness down here, okay?
Okay.
Do you have anything there?
No.
What about there?
No tenderness.
Okay. So go ahead and lean forward for me. We're looking at your spine. The spine is midline. It is straight. There's no signs of scoliosis. Go ahead and sit up. Her anterior-posterior diameter is rated a 2 to 1 because 2 to 1. Alright, so now we're going to be looking at your abdomen, okay? Go ahead and lay down the pillow. It's a little crunchy. Do you need your feet out here? A little bit? Okay. So first I'm going to be inspecting the abdomen. Then I'm going to auscultate, percuss, and palpate. Okay? So it is, the abdomen is flat, the contour is flat. There is no obvious signs of lumps or bumps or abrasions. So I'm going to be listening to your bowel sounds in all 4 quadrants. Sorry, I always do that. You're good. Okay, bowel sounds were heard in all 4 quadrants. If not, I will listen for a little bit longer, up to 5 minutes. So now I'm going to percuss. So down here in the right lower quadrant, it's going to be a tympanic sound. Up here in the right upper is going to be dull because of the liver. As well as over here, it's going to be tympanic until you get over to the spleen, to be dull. And then also tympanic down here. Your aorta is right above the umbilicus, which it is midline, as well as your bladder is midline as well. Okay? So down here in the right lower quadrant, it's going to be the appendix and the cecum. Up in the right upper is the liver and the gallbladder. Left upper is the spleen, stomach, and the pancreas. And then the right or the left lower is the sigmoid colon. Did you have any tenderness in any of these areas?
No.
No? Okay, great. So I'm going to have you set. When the patient set up, there was no signs of jugular vein distension. So that is good. I'm moving down to your legs here. Okay, the temperature is warm to the touch. I'm feeling your popliteal pulses.
Okay.
Your pulse is rated at a 2+. It's equal bilaterally. Go down here to the feet. There's no signs of edema. The posterior tibialis is also rated at a 2+, and it's equal bilaterally, not bounding. The dorsalis pedis pulse, you can find it. It's good. It's equal bilaterally, also rated as a 2+. There is capillary refill of the toes, rated at a 3 seconds or less. And we're doing a little tickle test on you.
Okay.
Test, okay? Alright, so it is a negative Vinci test because her foot went down instead of up. So go ahead and sit or stand up for me. I'm going to have you walk to the wall. And then walk back. Go ahead and stand. And you could stand there. Go ahead and put your hands up for me. Close your eyes. And she would stand there for about 20 seconds. Do you feel dizzy at all? No? No? Okay, you can open your eyes. So she passed the Romberg test because she did not feel dizzy. Now, are you in any pain at all? No? Okay, you can go ahead and sit down. And that will complete your head to toe assessment.
Thank you.
Thank you.
Okay, so that's the type of assessment that I want you guys to participate in doing. It's pretty easy. They don't require a complete head to toe physical examination during every 24-hour stay. The patient does require consistent specialized examinations at least every 8 hours that focuses on certain parameters depending on what they come in for. Uh, Daily weights, abdominal girth, or circumference of a limb must be taken very carefully. So you want to look at that type of thing. Usefulness of such measurements depends entirely on the consistency of procedure from nurse to nurse. Also, remember that many assessments must be done frequently throughout the shift, depending on what the order is, depending on what the situation is for that particular patient. Okay, so as you perform the sequence, take note of anything that will need continuous monitor. If they got like a high blood pressure or pulse, or they need pulse oximetry. Uh, if you need breath sounds because they got difficulty with respiration. If there is no protocol in place for you for a particular assessment, then decide for yourself how often you need to check on a person's status. Your assessments must be thorough and accurate, yet you must be able to complete them rapidly without seeming hurried. Okay. Basic reassessment applies to adults in medical, surgical, and in cardiac step-down care areas. Each assessment must then be specialized to each adult, and findings must be integrated into your complete knowledge base regarding that particular patient. This includes what you read in the chart, what you hear in reports, what type of laboratory tests they have, any type of imaging like MRIs, CT scans, all of that type of thing is what you take into consideration when you do a patient. You got to look at the patient holistically. Okay, so when you go into the room, you gonna look at the door and you gonna look and see is there any type of precautions or isolations, allergies, fall precautions, or anything that you need to be aware of. Once you into the room, you got to introduce yourself as that patient's nurse for the next 8 hours. And when you talking to them, make sure you make direct eye contact and ask how he or she is feeling, how he or she spent the previous shift, and whether he or she is having any pain or discomfort. Once you're in the room, refer to what you have heard from previous shifts, like when you got report. Um, because a lot of times a person will tell you, they'll be like, "Oh, they just asked me that," you know, that type of thing. So you gotta make sure that unless it's something like they on certain vital signs, just let them know in advance. But if you've heard something, um, when you got report from the previous nurse, when you go in there to see your patient, address that. Offer them water unless they are NPO, nothing per oral, and you want to note whether or not the person can hear you, can they follow directions, uh, whether or not they can swallow adequately, all of those type of things. As you collect this data and any other subsequent history, make sure that you notice the person's general appearance. Complete your initial overview by verifying the correct name band that has been applied to that particular risk of the person. You want to look at their general appearance, We all have been doing facial, body position, level of consciousness, skin color, nutritional, speech, and hearing. All of these things you want to make sure that facial expressions are consistent with what's going on with the person. Skin color is consistent with their racial heritage, whether or not they alert, whether or not they oriented. You want to get all that information. And you may not have to just ask the person. It may be based on just information that you're doing by just observing them, you know, and you don't have to make everything like common that you're observing uh for this particular thing. You don't necessarily have to say that to the person. You want to do your measurements of vital signs, temperature, pulse, respiration, blood pressure, pulse ox, pain rate. If you have to give pain medication, always make sure that you always come back and evaluate that person about 15 minutes after, if you give it IV, through the IV, and if it's orally or whatever, come back within the hour to make sure that there's some assistance. So you're always going to evaluate when you do something to a patient, you guys. Always go back and see how is that helping the patient. You're going to look at the neurological system, of course. You're going to look for ptosis, facial droop, motor, verbal response, if the pupils are reacting, how they have their whether or not they have muscle strength. You're going to look at how they communicate, whether or not they can feel adequately, respiration. Uh, if they have on oxygen, you want to make that known. And how are they getting that oxygen? Are they getting that oxygen via a mask? Are they getting a simple mask? Are they getting oxygen through nasal prongs? You want to put what the oxygen level is. You want to put whether or not that person is using accessory muscles, or whether it's they're breathing with ease. You want to auscultate, comparing side to side, and you want to ask them to cough and deep breathe, and you want to see whether or not that person has any mucus. If they have something like, let's say they just had a surgery and they need to use an incentive spirometer or something like that, that's a good time to offer it to them. Cardiovascular, remember, auscultate the rhythm at the apex, see whether or not it's regular. Check the apical and the radial pulse, noting all the beats. If it's irregular, you have to count for a full minute. You want to make sure you check the heart sounds, check the carotid. You want to look at the capillary refill and make sure that's less than 3 seconds. Check for pretibial edema. You want to palpate the posterior tibial and dorsalis pedis pulse bilaterally. Sometimes you can't feel it. You might need a Doppler in order to hear it, because some people it's just very difficult for you to assess their pedal pulse. Uh, Make sure that the proper IV solution is hanging if they have any, and make sure, in order to assess the patient's needs, make sure the skin is good, warm, consistent. If the person is you want to pinch that fold of skin under the clavicle, you guys, for mobility and turgor. You want to assess whether or not there's any skin integrity or lesions or problems or conditions. Complete any standardized scales using to quantify risk for any type of skin breakdown, and if they have any type of special mattresses or anything like that, make sure that they're functioning adequately. During the abdomen, you want to assess for bowel sounds as you saw the young lady do. Check for any tube placement for drainage and insertion, like a JP drain, or if they have a G tube or they're getting feeding, whether or not they're having active stool, if it's just a device present, when they had the last bowel move, whether or not they have a colostomy or ileostomy or something. Genital urinary, you want to assess if it's an odor. You want to assess whether or not they're distended. You want to look at the urine for the color and if it's clear, to make sure they don't have any type of infection. Sometimes people might need a bladder scan, and you'll look at your agency for their protocol, and it might be based on the fact that, well, this person hasn't urinated in 8 hours, so we're going to do a bladder scan. And that's something that I want all of you guys to see if you could possibly participate in doing a bladder scan, because it'll tell you exactly how many milliliters of urine is in the person's bladder. And it's pretty interesting. Activity, how they're ambulating, whether or not, if they can or not, uh, whether or not they require a device. And then you want to look at all your findings. And then as you look at all your findings, uh, you want to make sure that you do anything right away. Like for instance, right here it says blood pressure 160 systolic or less than 90 diastolic. Uh, I'm sorry, less than 90. Okay, systolic. I'm sorry. So if the blood pressure is less than 90 systolic or greater than 160 systolic, you that requires assistance. If the temperature is too low, if the heart rates are not between 60 to 90, if the respirations are off, if the O2 sat is less than 92, if they have a urine output of less than 30 milliliters in an 8 hour span of time, or 30 milliliters within an hour or 240 milliliters within 8 hours, they may be distended. It may be something wrong. If they have dark amber or bloody urine, you want to assess that. Post-operatively, if they have nausea and vomiting, some people are allergic to certain anesthesias. Surgical pain, and it's not controlled by medication. Well, that may mean they might have an infection. If a person is not having no relief and they having surgical pain, it may be something wrong. And then also you want to look at their level of consciousness, if they're bleeding, and how they're sleeping at night. So you need to electronically record data that's relevant for the person uh, through or via the electronic health records. Okay. And they say don't include this as part of billing and scheduling. So it's just data relevant to their clinical status. Make sure you do safety. Computer physician order entry is CPOE. I know that y'all probably have learned all of this stuff in intro, because that's what we do. Barcodes. There are various different things that people use to assure safety, assure you're not giving people the wrong medicines, or you're scanning the right thing. Uh, as far as SBOR communication, that's important. You're going to put the situation, you're going to put the background assessment, and what you recommend when you do your assessment. So if a nurse is preparing discharge planning for a hospitalized patient, when should the nurse start discharge teaching? The answer is one, the nurse should start discharge teaching upon admission. Case study for S-bar charting. You got a scenario here with a Mr. Edwards. You can read that scenario. And then if you want to, you could do a S-bar, put what the situation is. Because what the situation would be, the situation is that he had a headache and he came to a local medication local medical clinic. Background saying that the patient is 6 out of 10. I mean, he's basically saying that this been going on and off for several months. Okay, and then you do your assessment. So your assessment is things that, and your background will be things like if you knew this person had a high blood pressure, if you knew that this person was this or that, that would be in the background. Assessment wise, you will put the orientation, the pain level, the right eye is 3 plus, and the left is 5 and 9 reactive. He's having a clonic tonic seizure, how long it lasted, and then all your vital sign, all your vital signs and all that stuff, go up under assessment. And then whatever you do for that particular patient is what your response is going to be. So that's how you do a S-bar. So that's basically you guys in. Um, Uh, but I just want to say good luck. It was really fun having you guys. I look forward next quarter because it'll really be exciting for you guys. I know it's been a lot going through all of this with the pandemic and everything, but just keep your chin up. Like today, you saw what happened to me, and I was all worked up, but then I just calmed myself down and I said, there are certain things that you sometimes can't control. And then we just gonna take it from here. So good luck on the test. I'll see you guys just for checking in tomorrow. Thank you. Bye.